Hi, my name is Keandra Francis, and I'm going to briefly talk about rheumatoid arthritis. Rheumatoid arthritis is an inflammatory disease that causes pain, swelling, and loss of functions in the joints. This is a common disease that we may see in a clinical setting. Personally, I have seen patients with different severities of RA at the clinic I'm currently employed, so it is something that you do see in a clinical setting. Individuals with RA, also known as rheumatoid arthritis, immune system attacks their own cells within the joint capsule. The joints that are most commonly affected are joints of the hand, like the PIP and the MCP joints, the wrist or small joints of the foot, including the metatarsal phalange, the MTP joint. Also, shoulders, elbows, knees, and ankles are also affected with patients that have RA. The immune system attacks the thin layer of tissue that lines the joint called the synovium. Literature states that RA is usually due to the deterioration of white blood cells. These white blood cells make up the normal immune system. These said white blood cells travel to the synovium, which causes inflammation called neuritis. Neuritis causes the joint to become tender and puffy. That's where the inflammation is coming from. Synovium thickens into a tissue called pannus, which causes the scar tissue to form and eventually fuse the bones together. Over time, the abnormal synovial cells destroy the cartilage and the bone within the joint. The surrounding muscles and ligaments become weak, making it difficult to walk, so decreased mobility. This also leads to deformities. For example, this can lead to structural deformities. Structural deformities are the most common deformities that you might see, especially in the foot region, such as hallux valgus, which is the most prevalent. You might also see pes planus foot type with an added risk of ligament laxity or a subtalar joint inflammation. Rheumatoid arthritis is known as the most common form of inflammatory arthritis. 1 out of every 100 Canadian adults have rheumatoid arthritis. So that's approximately about 300,000 Canadians that have rheumatoid arthritis. It can develop at any age, but is commonly seen in adults ranging from 40 to 60 years old. Most severe cases are seen in the older adult population, so 60 plus. Hence why we decided to focus our research on the older population. We'll get into that a little bit later. Women are more commonly affected than men, but as I stated, this can start as early as 18 to 20 years old, sometimes even 25 years old. And as the individual age and gets older, so that the risk, the signs, the symptoms, and even the severity can increase. There are different stages of RA that I will briefly go over. Stage 1 is early rheumatoid arthritis. In the autoimmune process of RA, the body mistakenly attacks its own joint tissue, as I stated. So, in this early stage, patients may not have symptoms but expect some stiffness, especially early in the morning, primarily around the small joints. So, for example, the hand, the foot, they can feel some stiffness within the big toe, the hallux, or the metatarsal joints, the MTPJs. Stage 2 is when the antibodies developed, and that's when the swelling worsens. In many cases, RA progresses to the second stage without being diagnosed. In the second stage, if the patient does end up doing blood work, which is something as professionals, we can recommend. You can see the antibodies shown in blood work, and the joints can start swelling as well. During stage 3, symptoms are visible. In later, more severe stages, blood tests, imaging are less relevant because you can actually see the effects and structural deformities of the disease. For example, the joints start to become bent and deformed, which you can see in the toes, for example. These compressed joints can also press on nerves, causing severe nerve pain as well. And the final stage, stage 4, is when the joints become fused. If not treated, the disease will progress to the last stage, which there is really no more joint remaining at all, and the joint is essentially fused. Luckily, with treatments such as orthotics, people can avoid this stage, and it's very rare when people get to this stage, but people can um, avoid this stage with proper treatment. As stated before, RA affects the small joints in the body. For example, there are many small joints in the foot. So therefore, it's common for rheumatoid arthritis patients to experience foot problems. In fact, it is about double compared to the general population. RA has negative impacts on the patient's mobility, such as ability to walk and perform daily tasks. This overall decreases the patient's quality of life. Some foot deformities that can be seen are lesser toe deformities such as hammer, mallet, and clotol, metatarsal subluxation, mid and hind foot, mid and hind foot issues. So as the disease duration increases, so does the damage. You may also see a hind foot valgus, and these are just all examples that you could possibly see in a with an individual that has rheumatoid arthritis. Even a gait is affected. Sometimes you may see patients walk in a pain avoidance pattern with an antalgic gait. Study shows that individuals suffer from will have a decreased walking velocity slash speed, a reduced cadence, increased double limb support, and decreased step strength. So all of this information makes me think, how can we as future podorthists and healthcare professionals help individuals suffering from rheumatoid arthritis? It has been suggested that custom foot orthotics can be used as an accommodated tool, um, which made our gears kind of turn. Our research tends now, so therefore our research is kind of investigating and reviewing literature to compare the effectiveness of over-the-counter orthotics versus custom-made orthotics and improving the mobility in older adults with rheumatoid arthritis. All right, to clarify, our aim statement or the aim statement of this presentation is to compare the effectiveness of over-the-counter inserts slash orthotics versus custom-made orthotics in pain management treatment for older adults with rheumatoid arthritis. So we did this throughout the presentation, we did this through different methods. So our first method is to meet with a Canadian certified podorthist to learn about their experience with RAs and to get their personal opinion about the effectiveness of different types of treatments. Method 2, we reviewed scholarly articles and literature to compare the effectiveness of over-the-counter inserts versus custom-made inserts. We also discussed inclusion and exclusion criteria, and we also discussed the clinical importance slash implications of our findings. So I had the opportunity to interview our podorthist. Her name is Lori Nielsen. She's been a Canadian certified podorthist for about 10 years. So I asked her, I brought up the question, I explained to her what we were doing, and here are some of her answers. She suggests that custom orthotics is a better intervention than over the counter because often individuals living with rheumatoid arthritis suffer from painful nodules and callousing in corns due to the added pressure points. So she believes that a custom orthotic is more accommodative to help with those issues like the painful nodules and the corns and the callousing, whereas the over-the-counter orthotic may lack. Due to the painful signs and symptoms of rheumatoid arthritis, it kind of depends. She says it kind of depends on the patient and the severity of the condition. So overall, in her opinion, from a clinical standpoint, it would be more effective to dispense a custom orthotic because it would be more accommodating. Whereas from a customer service standpoint, an over-the-counter intervention might work. For example, if a patient cannot afford a custom-made orthotic, an over-the-counter orthotic might be a better treatment. It's better than nothing, as she was trying to explain. So her overall theme is that it's better than having nothing at all supporting the feet. But it really comes down to a situational basis. It depends on the patient. So if a patient can afford a custom orthotic, it's best to do that intervention. Whereas if they have, from a social economic perspective, it might be better to do an over the counter.
To assist with our search of the literature for studies comparing the effectiveness of custom-made foot orthotics compared to prefabricated foot orthotics in pain management for older adults with rheumatoid arthritis, we met with the Western University librarian. The databases recommended by the librarian and searched were Scopus and the General Western University database. The search strings used were rheumatoid arthritis and ortho, or insert, or insole, or inner shoe, and old people, or elder, or aged, or senior, and custom or custom made, and North America, or Canada, or United States, or Mexico. The asterisks denote the various endings a root word could have. For example, ortho could be orthotic, orthosis, or orthoses. With these 5 search strings, no results were found, so we removed the 5th string with the geographic inclusion criteria.
Method number 3 is our inclusion and exclusion criteria. This is the criteria that we based our research articles off of when we were looking for them to include in our final project. We had a few more of the inclusion criteria than we did in our exclusion criteria to make sure we were open with what we were looking for and to gather as much information as we could to finally put into this project. Our inclusion criteria included older adults age 65 and over. The articles need to be completed within North America, so Canada, United States, or Mexico. Completed within the past 10 years to make sure the information was relevant that we were gathering. And we want to specifically look at rheumatoid arthritis, not any other inflammatory arthritises or osteoarthritis. We wanted to look at specifically at rheumatoid arthritis. We also wanted these articles to be looking at the realm of orthotics or podiatrists, definitely foot related, not whole body or holistically approached. And we wanted to look specifically at pain management. A lot of the symptoms that these studies were looking at were subjective rather than objective, so pain management was something that we focused on. For exclusion criteria, we eliminated any articles that were in non-English, any adults that were less than the age of 65. Podiatrics were obviously out because we were looking at the age of 65 or over. And we also looked at were they truly comparing custom casted foot orthoses versus over-the-counter inserts. We didn't want to look at articles that included over-the-counter versus over-the-counter. We truly wanted to look at custom casted orthotics versus an over-the-counter product in these studies. I wanted to provide just a few articles that we found that we thought were relevant, kind of our top picks when we were looking at this research article and why we selected them. The first one was a qualitative study exploring the experiences and perceptions of patients with rheumatoid arthritis before and after wearing foot orthoses for 6 months. So this did not compare custom casted orthoses to over-the-counter, but it definitely looked at something in the realm that we were looking for. It was 6 female participants with rheumatoid arthritis wearing foot orthotics for 6 months. In Spain, it was completed. And explored the experiences of people with RA before and after wearing the foot orthoses over the 6-month period. It's concluded these patients reported wearing foot orthoses can have a positive impact on physical activity and improve general wellness and quality of life. Very basic and conclusions what they found. The second one was a protocol. It was a randomized controlled trial with prefabricated versus customized foot orthoses, so much better in the realm that we were looking for. Again, but this was completed in the United Kingdom and not in North America. This one had much larger because it was looking at different control trials. It was 160 people it was looking at. The outcome was collected on baseline at 6 months and 12 months, and is used to evaluate the comparative clinical and cost effectiveness of customized versus prefabricated orthoses for this treatment in early rheumatoid arthritis and foot conditions. 3 reviews investigating this article are underway, so there is no conclusions right now to look at, so it is something that they have put forward and they're going to be looking at further. The third article is the effectiveness of foot orthoses in patients with rheumatoid arthritis related to disability and pain. Again, something very common that we're looking at and meets our inclusion criteria. The aim of the review is to determine effectiveness of foot orthoses in patients with rheumatoid arthritis in comparison with other treatments in terms of enhanced disability and reduced pain. It was completed looking at different articles, so it was a meta-analysis, and it wasn't a true article or study that was completed during this time. 5 studies had about 301 participants, with follow-up periods of 4 to 36 months later. Although the use of orthotics seems to alleviate foot pain, the meta-analysis did not reveal statistically significant differences between control or intervention groups in this study.
Based on our search criteria, we found no studies comparing custom-made orthotics to prefabricated orthotics and their effects on pain for individuals with rheumatoid arthritis in North America. As such, we removed this inclusion criteria and our search yielded results primarily out of Europe. The literature supports the use of orthotics as an intervention to reduce pain for individuals with rheumatoid arthritis. A statistically significant reduction in pain level has been found with the introduction of foot orthotics. While the difference between custom-made and prefabricated was not statistically significant, it could be clinically significant. Prefabricated orthotics have been found to initially show a reduction in pain, but this reduction disappeared over time, whereas this did not occur with custom-made orthotics, and pain reduction was maintained. Also, the reduction in pain was greater with custom-made foot orthotics compared to prefabricated, and the reduction in pain was noticed more quickly as well. While there was minimal difference in foot disability and foot function between groups, the custom-made orthotic group experienced a more positive impact on these measures. In one study exploring individuals' perceptions to orthotics and their effects, participants not only reported a decrease in pain, but that they were able to increase their physical activity engagement, improving their general wellness and quality of life. It was reported that it took time to become accustomed to the foot orthotics, and there is a period of initial discomfort due to the introduction of the orthotic that passes before pain relief is experienced. Some have found that the ability of foot orthotics to reduce pain is most effective when paired with appropriate footwear. There were several limitations within the studies. They had relatively small sample sizes that were predominantly women, which could be owing to the greater prevalence of rheumatoid arthritis in women. Also, the time period over which the orthotics were used was of a shorter duration, and future studies should assess the long-term impact of orthotic use.
In our discussion, our group talked about why we were limited in some of the findings we did for this research project and where we think some of the bottlenecking was happening when we were looking for our articles. First and foremost, our inclusion and exclusion criteria was very limited. We looked at the age 65, having rheumatoid arthritis, and the research articles need to be within 10 years and completed within North America. This put a huge hurdle on us when we were looking for these articles. A lot of these articles we found that were good and that we referenced earlier in our project were completed in the United Kingdom or in Spain. So definitely limited in a gap of articles that have been completed within North America. And probably some more research can be done in this area. So there's a gap in the literature. Also looking at rheumatoid arthritis too. Osteoarthritis is a much more common pathology that is researched rather than looking at a niche pathology such as rheumatoid arthritis. And as Keandra mentioned earlier in a slide in our project, that there's a smaller sample size. Her statistic of 1% of adults in Canada are affected by rheumatoid arthritis limits how many participants can have it in a study. So this was also something that limited the amount of research that we found. The articles were also very shallow. They didn't have a whole lot of availability in the content they were looking at or the quantity or quality that we were looking for as well. Sometimes they didn't describe what kind of devices were being used. They just said they were custom casted versus a over-the-counter, and they didn't specify or characterize what was being looked at in some of the articles we found. And also if we look at another bottleneck in these articles we found was just the nature of rheumatoid arthritis. The pathology is going to be different from person to person. The joints they affect are going to be different from person to person and case by case. So comparing and contrasting similar joints within similar people is hard to do when we're looking at this kind of stuff. The severity of rheumatoid arthritis can be affected in different people. So studying the effects of the orthotic and the subtalar joint or the mid-tarsal joints when we're looking at a custom casted orthotic or a over-the-counter was a main point that we've struggled with. We also looked at pain management as well in a lot of our articles. So looking at, did they compare and contrast pain managements and more symptom-based results, or was it gait-related? Because we didn't really look at gait-related topics. It was, does this increase or decrease pain when using one of these two orthoses? So those were some of the things we discussed and why we think we had such a bottleneck in some of the articles we found, and which made this a bit of a challenging project in looking at the literature.
It is generally accepted that foot orthosis can provide positive outcomes in treatment of foot conditions in patients with RA. Thus, podorsis should definitely consider this treatment option. However, there is a lack of clear evidence in our review of recent studies that can definitively support the use of foot orthosis for this patient population. Hence, it is important for the clinician to set up their own and their patients' expectations of foot orthosis treatment based both on their experience and current research. From earlier review, we know that RA can have very different types and locations of onset, as well as different severity. Thus, if a foot orthosis is to be considered for this patient population, clinicians need to decide on a case-by-case basis if an OTC or a custom foot orthosis will be more beneficial. Some factors to consider are presence of foot deformity caused by RA, severity of the condition, presence of other relevant comorbidities, ease of access for desired device to be used, and patient's willingness to use and follow the treatment. As we know earlier about the baby boomers, Canadian population over the age of 65 is quickly increasing, so clinicians should expect to see more RA patients in the future. Due to the lack of research on this topic in recent years, it is important then to keep up to date on new research. In conclusion, the use of foot orthosis in patients at or above the age of 65 for rheumatoid arthritis-related foot conditions can reduce their foot pain, improve their physical activity level, and general well-being. It is not definitively clear whether or not foot orthoses are better than other methods of intervention, but there is no indication that this treatment is harmful when used correctly. If foot orthosis is to be used for the treatment of foot conditions in rheumatoid arthritis patients, discomfort can be expected in those who are using foot orthosis for the first time, but this discomfort should be temporary. Compared to over-the-counter orthosis, custom-made foot orthosis can reduce pain sooner, generate less initial discomfort, reduce pain more effectively, and remain effective longer. Thus, it is more recommended when foot orthosis is to be used.